بسم الله والصلاة والسلام على سيدنا محمد وآله الطيبين الطاهرين وأصحابه المختارين. السلام عليكم ورحمة الله وبركاته. The first lecture in this course will be about the evidence-based strategy for prevention of postpartum hemorrhage. As we know that prevention is the first thing to be done before the complication occur. An ounce of prevention is worth a pound of cure. درهم وقاية خير من قنطار علاج. Let us explore the causes of maternal death. Maternal death can be prevented by understanding the cause and eliminating it. If we look for the causes of maternal death, we'll find the majority, which is 28% of the maternal death, is due to the indirect causes, whether we are talking about the heart diseases, diabetes, malaria, and mental health condition, and others. 27 for known causes, 27% caused by severe bleeding, whether we are talking about bleeding antenatally or postpartum, first, second, third trimester, and postpartum. But the leading cause of the bleeding is occur in the postpartum period. 14% is due to the hypertensive disorder, such as preeclampsia and eclampsia, and 11% is due to the sepsis and infection during pregnancy or in the postpartum period. Complication of abortion form 80%, where unsafe abortion remaining a major cause in many countries, and obstetric prolonged labor delay in the treatment can lead to severe complication. So most maternal death occur during the pregnancy and childbirth or within 42 days after the delivery. There is multiple risk factor which can precipitate and exaggerated the form of maternal death, like limited access to the quality health care, poverty and low education, delay in receiving the care, and shortage of training health professional, lack of education, lack of essential medication, and lack of blood product. With skilled care, proper resources, and timely intervention, most maternal death can be prevented. The strategy to prevent the maternal death is going through strengthening the health system, empowering the woman and educate her, ensuring access to equality care, and remember that you have to educate your staff how to handle first, how to predict, how to prevent, and how to act if it's occur. So every action is count and every woman is matter. Maternal mortality can be caused by one of the major causes, which is the hemorrhage, hypertensive disorder, and sepsis. Chronologically, hemorrhage is forming 27%, hypertensive disorder cause of maternal death is 14%, and sepsis is 10.7%. During this course, we are going to cover the hemorrhage and how we are going to predict, prevent, resuscitate. And in the next courses, we are going to cover the hypertensive disorder and sepsis. Every time you are hearing about postpartum hemorrhage, you are thinking about what I'm going to hear about a new modality of prevention or diagnosis or treatment. But today we are going to concentrate about the prevention, early diagnosis, and the new modality of early diagnosis and estimation of blood loss, and resuscitation and treatment, whether it is medical treatment or surgical. As you can see, the postpartum hemorrhage causes a major maternal morbidity and one of the top 3 causes of maternal mortality. Where the delay recognition and limited access to the essential medication, unavailability of blood, unavailability of surgery, or shortage of trained staff make a high risk of maternal death. Whereas in the opposite, if there is timely recognition, access to the uterotonic medications, availability of blood and blood product, and transfusion, and the presence of expert surgeon and trained persons can end up with better outcome. You can see the difference where the low-income country, the maternal death due to the postpartum hemorrhage form 1 per 1,000 birth. In contrast to the high-income country, whereas the death is 1 per 100,000 birth. So postpartum hemorrhage is preventable. Every woman, every birth, every time, all should be accounted to prevent the postpartum hemorrhage from occurrence. And if they occur, we have to know how to handle them. I do think that one of the major causes of maternal death and severe postpartum hemorrhage and the complication of severe postpartum hemorrhage is that we are underestimating the blood loss. Causes of postpartum hemorrhage. When we are talking about the causes of postpartum hemorrhage, most probably we are talking about the 4T. The T, the tone, which is forming 70 to 80% where the uterus is failed to contract it. There is several risk factors like prolonged labor or rapid precipitated labor, overdistension of the uterus, whether we are talking about multiple pregnancy, polyhydramnios, or the macrosomic baby, grand multiparity, oxytocin overuse, and chorioamnitis. When we are talking about the trauma, which is forming 20%, we are talking about trauma anywhere in the genital tract, whether we are talking about the trauma in the starting from the uterus, we are talking about uterine rupture or uterine inversion, talking about broad ligament hematoma, going down to the cervix, cervical tear, going down to the vagina, vaginal tear, or perineal tear, and episiotomy bleeding. Hematoma could occur, like we know, it's either vulvar or vaginal hematoma or broad ligament hematoma. When we are talking about the 30, which is the tissue forming 10% of the causes of the postpartum hemorrhage, we are talking about the retained placenta and retained placental fragment or placenta accreta spectrum, whether we are talking about accreta, increta, percreta, or retained membrane. The fourth one is the thrombin, which is less than 1%, and is due to the coagulation disorder like disseminated intravascular coagulopathy or severe preeclampsia and HELLP syndrome, abruption placenta, amniotic fluid embolism, and congenital bleeding disorder like von Willebrand disease, and anticoagulant therapy. Since uterine atony is responsible about 80% of the cases of postpartum hemorrhage and considered to be the leading cause of postpartum hemorrhage, so the question which is coming, can we prevent uterine atony? The answer is yes, we can. By active management of third stage of labor is going to significantly reduce the incidence of postpartum hemorrhage. We talk about active management is simple, safe, effective practice that make big difference. To prevent postpartum hemorrhage by 60%, do an active management of third stage of labor. Active management of third stage of labor is form of administration of uterotonic agents, control cord retraction, uterine massage, and checking for the completion of the placenta. When we're talking about uterotonic administration, you will find different people talking in different language and administer different medication, and everybody is believing in what he's doing. In this lecture, we are going to talk about evidence-based, what is the best medication for uterotonic administrations. Simply keep it as oxytocin 10 unit intramuscular or intravenously immediately after the delivery of the anterior shoulder of the baby. Control cord traction. Apply control traction on the cord by supporting the uterus. It's very important to know how to support the uterus, not pulling down. It is just support up. By doing pulling down, you might end up by uterine inversion, or you might end up by subtotal uterine inversion, which can be from one of the causes of the severe postpartum hemorrhage. Uterine massage after the delivery of the placenta of the uterus ensure it is firm. So uterine massage after prophylactic oxytocin is not considered the principal medication-based preventive intervention. So no need for exaggeration, just do gentle massaging because it's really painful to do the massaging and vigorous massage. Vigorous massage is done when you are not administered uterotonic agents in certain area where it is not available, or if you are suspecting that the patient she start developing, then you will do gentle also uterine massage. Checking for the completion of the placenta to be sure that there is no membrane or no cytolidome is missing. The benefit of the management third stage of labor, active management of third stage of labor, is to reduce the risk of postpartum hemorrhage, reduce maternal morbidity and mortality, and improve maternal recovery and save lives. With simple measure, you can save lives. Coming back for uterotonic agents, WHO and FIGO continue to recommend oxytocin as 10 units intramuscularly or intravenously as the first-line prophylactic uterotonic. Carpitocin there, misoprostol is there, ergometrin is there, an alternative when oxytocin is unavailable, unsuitable, or cannot be stored correctly. Talking about the comparison of uterotonic, the Cochrane database systematic review done in 2025, showing the evidence summarized and compare between the oxytocin and the other agent. Oxytocin plus misoprostol, approximately 30% relative reduction in the postpartum hemorrhage, more than 500 ml. Carpitocin alone, broadly similar efficacy as oxytocin. Oxytocin plus ergometrin, approximately 24% reduction in postpartum hemorrhage. Misoprostol alone, less effective for prevention of postpartum hemorrhage. The combination regimen improving efficacy but having the highest frequency of adverse event. So still, the first line of management is oxytocin. If we need to give the carpitocin, ask me about myself when I will use carpitocin. Carpitocin is a long-acting systematic oxytocin analogs that bind to oxytocin receptor in the uterine myometrium, producing strong, sustained uterine contractions. So where is the cases where I use carpitocin? It have been proving it is superior to the oxytocin in cesarean section, so I'm using it in cesarean section. I'm using it for twin pregnancy, for patients with polyhydramnios, patients in prolonged use of oxytocin, particularly the second stage of labor. You will find that oxytocin alone is less effective and receptor is oversaturated, so carpitocin might be better in such a situation. So in conclusion, the Cochrane review concluded that active management of third stage of labor significantly reduced the postpartum hemorrhage and may reduce severe postpartum hemorrhage comparing with the expected management. And WHO and FIGO concluded that routine active management of third stage of labor reduced the postpartum blood loss, decreasing the incidence of postpartum hemorrhage, and reduced the need for additional uterotonic medication. Training and education for the management of postpartum hemorrhage should including all the obstetrician at all the level, consultant, senior registrar, resident, and even the intern, as well as training for nurses and midwife. And the anesthesiologist also should be involved in the training of the management of postpartum hemorrhage. The Cochrane Review 11 study, 2,635 women have been reviewed, randomized controlled trial, which is compare carpitocin with other uterotonic agent or with placebo or no treatment for the prevention of postpartum hemorrhage. Where the conclusion is comparing to oxytocin, carpitocin associated with reduced need for uterine massage following both cesarean delivery and vaginal delivery, Pooled data also show that the carbetocin result in a low risk of postpartum hemorrhage comparing to oxytocin in women who underwent cesarean delivery. And there is no statistical significant difference in terms of need for therapeutic uterotonic agents, but the risk of adverse effects such as nausea, vomiting were significantly lower with the carbetocin. For the meantime, I use carbetocin for the prophylactic for postpartum hemorrhage in cesarean section. If you look for the prevention and how it's progressing from the year 2020 to 22, till now, there is no much big difference. You can see that the vaginal delivery for the prevention of postpartum hemorrhage, we are using oxytocin plus continuous cord retraction, not different at all. But in cesarean section, carbetocin plus 100 microgram intravenous in 2020, and they added tranexamic acid if antepartum anticipated postpartum hemorrhage, and it is not changing till now. So in cesarean section, we are using the carbetocin plus tranexamic acid if anticipated postpartum hemorrhage. Thank you for your commitment to excellency in women healthcare. Together we are shaping safe care, improving outcome, and supporting every woman at every step. Reference for the prevention of postpartum hemorrhage.